Let's now turn the discussion to talking about the use of systemic therapy in patients with locally advanced disease up front. Kevin, what are some of the triggers to add chemotherapy to radiation?
Well, the guidance is very clear in this regard. It should be patients with stage 3 or 4 disease. It should not be used in earlier stage disease. We would consider patients who are younger than 70 years of age to be eligible for this treatment. We know, as I've already mentioned, that the meta-analysis doesn't support the use of concomitant chemotherapy in older age groups. And although that may be controversial, and there may be some who maintain that you can define biological age even in an older age group, I would contest that view. And so we would tend to use cisplatin as a monotherapy. The practice in Europe, and Viktor may have some comments on this, the practice in Europe includes perhaps carboplatin and 5-FU, and in the NCCN guidelines that's also included as one of the options in this regard. We would use cisplatin conventionally at a dose of 100 milligrams per meter squared every 3 weeks, and again that's in line with guidance. There is a tendency in many of the centres, and indeed some of the lower volume centres, maybe some of the less experienced centres or more community-based centres within the UK and elsewhere, to use a regimen that's perceived as being a little gentler, which is 40 milligrams per meter squared every week. I think in fact that's not correct, and I think the data support the fact that that is just as toxic as 3-weekly chemotherapy. It isn't in fact kinder to patients. And I think there is now a real concern that it's less efficacious as well. So the gold standard is clearly 100 milligrams per meter squared of cisplatin delivered every 3 weeks during a standard course of radiotherapy.
And for advanced stage patients primarily, Viktor, let me turn to you. You talked about the postoperative setting earlier. When do you use chemotherapy in the postoperative setting?
I actually would like to comment on what Kevin said.
Please.
Because I think the 100 milligrams are really controversial, aren't they? I mean, because it's per guidance, it's what you should do. This is where we have clear evidence for. So the question would be, I mean, if you're not doing the full, or you consider the patient not able to go through the whole course of full dose cisplatin, what do you do with these patients? I mean, what would be your alternative approach? So is there, you go down to weekly dosing, you switch to cetuximab, or how do you manage this? Because I think these are the concerns that the doctors have that go for weekly dosing, aren't they?
They are indeed, and in fact we very infrequently use cetuximab as an alternative. We would tend to use actually quite often carboplatin instead of cisplatin, and indeed we conducted a matched pair analysis to show that there was no significant detriment to patients. Now, I know that doesn't carry the same weight as a meta-analysis or a randomized trial, but it gave us the reassurance that giving carboplatin instead of cisplatin was a reasonable approach in this group of patients.
And Viktor, let me, so we don't leave that post-operative question hanging, what are the parameters that you use post-operatively to add chemotherapy?
For add chemotherapy, so basically this is when it comes down to lymph node invasion, and if it's, as Kevin said, it's stage 3 and 4, and if you have spread within the lymph node beyond the capsula, for instance, that would be a trigger for us to really add on chemotherapy when we consider radiotherapy per se is not enough to really to deliver to that patient as post-operative treatment.
There's also the other, of course, consideration at the primary tumor site as well. And there is, of course, some controversy around that as to whether or not it is the so-called R2 resection less than 1 millimeter margin or the R1 resection 1 to 5 millimeter. And I think the unified guidelines are clear on this, that it's tumors where there is an involved margin of less than 1 millimeter, the addition of platin-based post-operative chemoradiation yields a benefit in terms of loco-regional control and survival in the European study at least.
Yeah, and I think most of us would approach it exactly as you said.